maybe like the concrete numbers of the ventilators and available beds available at Shannon or in this region? Do you have that number? Okay,
I do have the numbers for Shannon. I'm not, completely familiar with the regional numbers. Those, I assume, are the ones reported on the Texas State dashboard. So I don't know anything more about those than, what shows up on that daily report. But as for Shannon, we have 400 licensed bed, and we have 19 beds in the ICU. We have 33 ventilators, and then we have quite a few other ventilator-type machines that we could use in case we needed extra ventilator support. I'll just say that the way the treatment for COVID-19 has changed significantly since the onset of the pandemic back in February and March. Originally, patients were put on ventilators early in the course of the disease, and that was thought to be the best care for the patients. Nowadays, ventilators are used as a last resort, so even here at Shannon, we very infrequently use ventilators in these patients. We use other non-invasive ventilation type apparatuses like CPAP or BiPAP or high-flow oxygen or other oxygen providing devices that do not require the use of a ventilator.
All right, I know when I had spoken with Dr. Bredis a few weeks ago, he had mentioned the possibility of having patients from other cities. He had talked about Eagle Pass, San Antonio had reached their capacity, so they were sending patients over here at Shannon. Is that a concern for you guys at all?
We have not, to my knowledge, had any patients come from outside the Concho Valley area at this time, nor do I know of any instances where that's been requested. Of course, our priority here at Shannon is to serve the patients of the Concho Valley, and our capacity and our plan for taking care of COVID was pretty much designed around those counties and that population.
And I do also want to ask is, once a patient is admitted into Shannon because of COVID, what are the next steps? How do you determine when that patient is released?
Okay, so when a patient is admitted with COVID, obviously the first step is to get a test. Most of the patients come through the emergency room. Occasionally they are transferred from another facility in our region or from perhaps a doctor's office directly to the hospital. So they have a positive test to start the process. Really, the next step is to assess the symptoms and how sick is this person. A lot of that depends on, their age and comorbidities, and but the big one is their oxygen level on room air. So normally that's going to be above 90% for most everyone. When we see someone who's positive for COVID-19 and it goes below 90%, then they're placed on oxygen. And that's probably the number one criteria for why we would admit somebody to the hospital. Everybody who comes to the emergency room, most of them have various symptoms: fever, fatigue, sometimes nausea, vomiting, diarrhea, and those type of symptoms a lot of times can be easily treated at home. But the one thing that is difficult to treat at home is a low oxygen level, because you need some oxygen support. That's where we end up placing the patient on. It can be either a small amount of oxygen or a large amount of oxygen via some of those devices that I mentioned earlier, a high-flow a high-flow cannula or a BiPAP machine, a CPAP machine, or if all else fails, a ventilator.
I'm not sure if you answered this already, but is there a COVID bed capacity right now?
I've been asked that question before. You know, like say, Shannon, we have 400 licensed beds. I guess theoretically we could have all of the beds full of COVID patients. What we've done is we have like a game plan where the COVID patients that come in, we have a staged game plan to separate them from the other patients that are in our facility for safety of the patients, the visitors, and the non-COVID patients. So to start with, we have a COVID unit on 2 of our floors, as well as a part of the ICU that are sort of dedicated to a COVID positive patient, and they have their own particular nursing staff and support that only work in that unit so as not to go back and forth between different types of patients. The game plan that was developed back in March and April was that if the capacity of those units is exceeded, then we have other areas of the hospital identified that we could add another COVID unit on a different floor. As you know, we also have St. John's, which was in the past a full-fledged hospital, but there are a significant number of beds out there that can be utilized as a unit. Those are currently being used as a rehab facility, but those are very adequate hospital rooms that can quickly be turned into a 3rd or a 4th or a 5th COVID unit. So with that availability to us, we can accommodate a significant surge in the number of COVID patients, far beyond what we have currently in the hospital.
Got it. At what point would you say we are in trouble?
That's what point are we in trouble? When we run out of nurses. I think we have, would like to say, we have bed capacity both here at St. John's, and we also work closely with community as well as the city. Dr. Veredis has helped us identify other facilities in the community that could house COVID patients of various degrees of illness. So there's always a place for them to go. If there were any limitations, it would be the licensed staff that are needed to take care of those patients. We're good right now, but as you hear from all across the state and regions, staffing would most likely be the issue if we had a very large surge of patients that came in all at one time. And I think a lot of facilities are bringing in staff from across the state or out of state right now in order to help with demand in some of the areas that have been hardest hit. And we would also plan on putting into effect a staffing plan to bring in outside nurses and nurses' aides to help us if we needed.
My last question is, what do you think the public should know as far as how serious things are in the cases?
If the point that I would make to the public is that we are going to be able to take care of the COVID patients that come into our facility. We also need to be able to take care of all the other patients who come into our facility. And those are patients with serious medical conditions, heart attacks, strokes, and trauma patients that come in here day in and day out throughout the year. We do not want to be in a position where we are not able to care for everyone who needs help, COVID or non-COVID included. The best way to do that, and I think Dr. Varetis has stressed this over and over, is to wear a mask, practice social distancing, wash your hands, and avoid being in large groups. That's not so much for the protection of the individuals as it is you're protecting a vulnerable population in our community from getting the best medical care, and you may be preventing people from being able to go to their jobs if it's mandated that things shut down again because of the number of patients. So I would hope people realize that to wear a mask is you're helping a lot of other people, even if you are not so concerned about your own health or well-being. There's a lot of people that are depending on controlling this pandemic in order to be able to go to work and to get good access to medical care when they need it.
With the recent surge in the numbers, how severe have the majority of the cases been?
What we are currently seeing is that between 10 and 15% of people are developing a more severe form of the illness. The large majority have very mild symptoms, maybe equivalent to a summer cold or bad allergies, but it's those 10 or 15% of the positive patients that are ending up in the hospital, requiring oxygen, requiring significant medical care here, and that's been our experience. As the numbers have increased, that number has stayed fairly consistent.
There's a doctor in Odessa who may have made new moves in discovering a cure or a different way to treat it. Is Shannon doing anything, not maybe out of the box, but just different, or maybe slightly different than any other hospitals around, just to treat these patients?
No, we have a COVID team which is led by an intensivist and a hospitalist, and they are in contact with several of the larger institutions, both within the state and out of state, as to what are the most up-to-date protocols for patients. As you've noticed from just over the past month or two, some treatments have come and gone out of popularity, and some have been disproven. Initially, they were this was the magic bullet, and now they are no longer FDA approved. So what we have done by design is to stick with the guidelines that other large institutions and academic centers follow, and we have updated our guidelines many times over the course, but we have not decided to do anything experimental or that has not been proven or adopted by, like say, some of the major institutions in the state. I think that's served us well so far. If what you're referring to turns out to be a miraculous advancement in treatment, as soon as that becomes more apparent by some verified study, then we would certainly adapt that. We use a form of steroids which is similar to what you're referring to. We use convalescent plasma from patients who have recovered from the illness. We use what supplies of remdesivir that we can obtain through the state allocation method, and then beyond that, we just use the standard protocols that are pretty much agreed upon across the country.
Is that the excuse me how I say it, right, hydrochloroquine or?
Hydroxychloroquine.
Yes, sir. Do y'all use that here, Shannon?
We did when it was being used elsewhere, and that has fallen out of favor and actually recommended not to use that by the FDA. So we're following those guidelines.
I know yesterday it was released that the numbers that are being reported don't include antibody tests, but however, is that something that Shannon does offer?
The antibody test is a great question because a lot of people are obtaining antibody tests across the state, nationwide. A lot of our patients here have acquired antibody tests through private labs. Currently, we are really focusing on testing for the acute illness with the PCR test. Is really what we use to identify patients who have the disease and really to identify people who have the disease who need treatment. There is a good antibody test that's FDA approved. I think it's made by Abbott, and that is the test that we've identified that we will use when the time comes. Right now, it does not really help us in the management of anything. The antibody test does not. Where it's really important is if a patient has had COVID-19 and they have a positive antibody test, I would strongly encourage them to go to the blood bank and offer to donate their plasma, and we use that, as much of that as we can, in our critically ill patients in order to help them recover. In consultation with the blood bank, a lot of the plasma that we are using is coming from the Northeast because there's many more people who have recovered from the illness up there, so they have these antibodies in their blood and are willing to donate. As the numbers increase in San Angelo and around the state of Texas, people who are willing to go donate their plasma will provide a great benefit to other members of the community who may get the severe form of the disease. They can go to the website for the blood bank, and it has a questionnaire and guides them through that process to donate the plasma. They do an antibody test on everyone who donates blood nowadays, so that's a way to get a free antibody test if you really want to know if you've had COVID. If you've had the test and you have your lab results that say you were positive, you can donate that plasma after 28 days. So, and they are, like I say, they are very interested in making that process easy for anyone who wants to donate. But that's a great way to use to serve the community for now probably I don't know the exact number, but hundreds of people who have recovered from the illness.
Now my next question is, there's been several more people that are being tested for the virus through the drive-through site. What is the turnaround time for those tests?
The turnaround test in the drive-through is currently 7 to 10 days.
And I know, there had been talk about doing in-house testing here at Shannon that could give you results in an hour or less.
Mm-hmm.
Where is Shannon on that?
Okay. Good questions. I just noticed watching the national news today that the testing is coming back as being the major problem now in controlling the pandemic. And I saw, reports from San Antonio, Houston, and New Orleans, I think, where now testing is limited. They are limiting people going through their drive-thrus. Some of the drive-thrus that we know of in Texas are shutting down because the labs that you refer the test to can no longer handle the volume. So the drive-throughs are a very successful way to get lots of people through and safely test them for the virus, but we've gotten so good at it that now the labs can't catch up. In addition, the testing supplies that go along with it, the swabs, the bottles, the reagent, which is the liquid inside that interacts with the virus, those are all in short supply. So outpatient testing is starting to sort of bog down with lack of supplies. The rapid turnaround test is also in short supply. So we have prioritized all our rapid testing to patients who are being admitted to the hospital that we need to know their status. Sometimes patients who leave the hospital that need to have a test before going to another facility, such as a nursing home or rehab facility. And also some of our frontline staff, physicians, nurses, who have had exposures or who have symptoms and are desperately needed to continue working. If they're positive, of course, they have to go home and quarantine themselves until they recover from the illness. But if they're negative, they can continue working. That way we're able to preserve our staff, and that's what most hospitals are doing now with the rapid test, is to because the supplies there are limited as far as what you're able to get from the manufacturers, and so you have to sort of ration that to the highest need cases, because we want to be able to we need to be able to maintain that testing for those groups and not risk running out. If we use those rapid tests for the drive-through, we would run out in a few days probably, and then we would have no testing for anybody. So that's where that stands. What I hear is that the testing is going to get worse before it gets better. So hopefully we can maintain the drive-through. I think that provides some community needs that they can't get elsewhere, and we'll continue to do that as long as it's possible.
And my last question is, are you capping the number of people that are being able to get tested through the drive-through, or is it just whoever comes at that in
As many as can get through by 5 o'clock, and they evaluate. They don't always test everybody, but they evaluate the need for testing. And nowadays they are testing most people who go through because they either have symptoms or a direct exposure. So most people do end up getting a test. It does take, like say, 7 to 10 days now to get the results, but that's really the best that those labs are able to offer right now.
I got a couple for you. So,
Yes, sir.
a month ago we had probably 0 in the hospital, and now we have 37 between the two.
Mm-hmm.
Is that cause for concern for the citizens of San Angelo? A lot of people see that and they say, well, we have 100,000 people, that's not a big deal, but that is a big deal, correct, that we have that many in the hospital?
It's a big deal if it continues to upward at that rate. I would agree with that. We've seen a leveling of that number here at Shannon in the low 30s for several days now. And so the number of admissions is pretty much balanced by the number of discharges. So that gives us some hope that maybe we're reaching a peak in that number. That number is very manageable. What we hope doesn't happen is that doubling of, every week or 2 weeks that was experienced in the Northeast, where you go from 30 to 60 to 120 to 240. That would give, I think, everybody cause for concern. Again, the way to prevent that from happening, again, is to socially distance, wear a mask, and help slow down the spread of the virus locally.